Camera's off and
Same.
mute, but I'm here, Sam.
Okay, awesome. Thanks, Candace.
If they are, they have to be really subtle elements.
Like taking a look at Henny's jacket right now down the zipper. Is that a level wear?
Yeah, this is durable and
yeah.
durable. Yeah.
Yeah, so quite tasteful actually down the zipper, which is what we've done in the past.
So my question is this: should we leave it as Casa on that zipper, and that's
No,
it?
we can't do the zipper for that one. There's no zipper location on that one.
Okay.
Nothing in my favor. I got the rain in my face and going home. Hey, hey, oh, 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 hey, hey, oh, oh, can't get enough sweet cocaine. It's up on everything. Rolling home with you. Hey, hey. You worried about my baby. You worried about wife. Just one place for a man to be when he's worried about his life. Going home. Hey, 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 oh, oh.
Welcome to the Breaking the Silence webinar series. My name is Candace Fair, and I am the Community Enhancement and Development Officer with CASA Foundation, which is the fundraising arm of CASA, Child, Adolescent, and Family Mental Health. We raise money to support CASA services and raise awareness about children's mental health. We are honored to be partners with the Mental Health Foundation to bring you Breaking the Silence. Both organizations are passionate about mental health care and are grateful that the Breaking the Silence team has brought us together to share resources and support with all of you. We are so happy that you're able to join us today. It is more important than ever to recognize and show our respect to the Indigenous people of our country through a treaty acknowledgement, which is an act of reconciliation to recognize traditional territory of the Indigenous people who were the first to call this land home. Today, we acknowledge that we are on sacred Treaty 6 land, the ancestral land of the Cree, Saulteaux, Blackfoot, Métis, Dene, and Nakota Sioux. And we recommit to our promise to live together on this land and take care of one another in these difficult times and always. So with today's session being virtual, just a couple housekeeping notes to be aware of. We will be recording our entire session today, and it will be shared with all of our participants afterwards. It'll also be available on the Breaking the Silence website for a limited time. We ask that you use the Q&A function to ask questions throughout this presentation, and you can do so anonymously. And then at the end, we will carve out some time to share those questions and have a Q&A with our presenter and a bunch of panelists. So here we go. Today's presentation hopes to educate on how to deconstruct ageism and destigmatize seniors' mental health. Our presenters will discuss wellness strategies, various mental health concerns, ranging from depression and anxiety to dementia and delirium, recovery, and also helpful resources. The Community Geriatric Psychiatry, or CGP program at Covenant Health is part of the continuum of seniors' mental health services serving the Edmonton zone. It is a specialized clinic consisting of a multidisciplinary team and provides mental health services to clients living in the community. Again, as I mentioned, at the end of the presentation, there will be a live Q&A period with a panel of healthcare providers from the CGP program. Our presenter today is Garima Khatri. Welcome, Garina, and thank you so much for being with us this afternoon.
Thanks, Candace. I'm gonna check in. Can everybody hear me? If you can't, please put in a message in the chat box. So thank you all for joining us, and thank you, Candace, for that wonderful introduction. I hope that everyone is keeping well and actively looking after their mental wellness, especially during these strange plot twisty times. As I begin, I do want to thank Raju Virk, Jag Atwal, the group of family, friends, and volunteers behind the scenes, the donors, the sponsors, CASA Foundation, and the Mental Health Foundation for continuing to put this incredible annual event on, even though there's been restrictions to meeting up in person. It's an incredible event, and I really appreciate that we continue to raise awareness about mental health, break the stigma around mental illness, and bridge those gaps and barriers to accessing help. These are very important conversations to be having, so thank you very much for that. I appreciate you inviting me and my colleagues to take part in this year's event. And so today I will present for about 45 minutes, and then we will have a live question panel with a group of my colleagues starting at 12:45, and they plan to be here for about 30 minutes. So what I'll ask is if you have any questions that come up, like Candace said, please type them in the chat box. You can direct message Candace as well, and we'll save all of those for 12:45. Just wanting to go to the next slide here. Okay, this presentation is not meant to replace professional assessment advice and/or treatment. My goal is to provide information and to start conversations. And I will be talking about later on sensitive topics of elder abuse and suicide. So I encourage people to look after themselves. If you're feeling triggered, maybe in your body, your thoughts, maybe to take a break, you could mute me. If you need to reach out for help, please do so and take care of yourself. The agenda today, I'll talk about the program in which I work, some important definitions, what is this thing called recovery, age-ism, and some selected problems and disorders and some resources, and then we'll have our question panel. So the community geriatric psychiatry is part of, like Candace mentioned, a continuum of geriatric services with Covenant Health. We're located at the Westmount Shopping Center. We have office hours 8 a.m. to 4:15, and we're closed on stat holidays. If clients are looking to have that support after hours, there's usually a geriatric psychiatrist on call through Access 24/7. Our clients are usually 65 years older and up. However, age is not an exclusion criteria. What this means is sometimes people have geriatric syndromes and they might not be 65 years old. And so we evaluate through our intake coordinator, everybody on a case-by-case basis. The access is by referral. Something kind of unique about our program is clients can self-refer, and if they need help filling out that referral form, they can reach out to our clinic and receive that support as well. The only exclusion criteria that we really have is that clients, if they're living in long-term care or designated assisted living, there's a different program actually to assist these clients, and so they wouldn't be receiving support from us. We serve the Edmonton zone, so Edmonton and some surrounding areas, and we, like I said, or Candace said, we have a multidisciplinary team. Is pretty robust. So our intake coordinator is a nurse. We have a team of geriatric psychiatrists. There's an assessment nurse, RNs and psychiatric nurses on our team. We have social workers, psychologists. We even have an addictions counselor. Referral concern, if somebody has a mental health issue and with addictions as well, that's appropriate for a program. But if addictions is the primary reason for referral, we would guide them to seek support at a more like a different program because ours is primarily focused on the mental health piece. A psychometrist is somebody who does neurocognitive testing. We have an occupational therapist on our team. We have day programs, so we have recreational therapists, recreation aides, and they call themselves the angels, the community support workers that support our the clients to stay independent in the community. We have some of those on our team as well, and then our mighty admin staff that seem to keep they seem to be the glue that holds us together some days. So what we do. Each person that's referred to our program, there's a comprehensive biopsychosocial assessment. And so we aim to provide individualized care. So it's client-centered to older adults living in their own home or in the community. So what people can seek out for is it could just be a psychiatric consultation, and then the care is taken over by another psychiatrist or maybe the family physician. With that being said, sometimes people want to be followed up by us, and they can receive that service from us. So it's the comprehensive biopsychosocial assessment. There's a treatment plan. There's some goals that are to be followed, and that follow-up, which can be short-term or long-term. Sometimes our clients come to us because they're being discharged from hospital. And so to transition back into the community, that short-term support is needed. Sometimes people have a complex situation, or maybe it's a long-term illnesses that are going on for them, or maybe there's multiple different things going on with their physical health and mental health. And so they require a longer term support, which we are able to offer as well. With our addictions counselor, we are able to offer that addiction screening, assessment, and counseling service. We have individual and group counseling at our clinic. These are for the clients of the program, so it's internal referral. We have a outpatient day program. There's 2 sites. One's right here at Westmount, and the other one is at Ermineskin. And we provide education and support for clients, their families, service providers, and stakeholders like right now. And we do liaise and provide referrals to other community agencies as well. So we really do have a commitment for collaborative care. Our program is a partner in the Seniors Protection Partnership. So that's the high-risk elder abuse team, which serves Edmonton and area. And it's a partnership in between us, the Community Geriatric Psychiatry Program with Covenant Health, the Edmonton Police Service, SAGE Seniors Association, Catholic Social Services, and the City of Edmonton. And the idea is, if a senior is experiencing elder abuse, that they're not going from service to seek that help. They reach out to one place, and it's the services that coordinate and collaborate with each other to provide the needed support for the individual. We're also a partner in the Hoarding Coalition team and a member of the Elder Abuse Consultation Team. So the Elder Abuse Consultation Team is a group of service providers, so programs and organizations that meet and they discuss if there's a situation of elder abuse and how can we collaborate across different programs, services, and sectors. And our program, it follows Alberta Health Services integrated addictions and mental health service model. So like I said, the short-term clinical intervention, and it could be intense or long-term treatment. So there's a number of different supports available, and I don't expect anybody to be able to memorize these or to understand what kind of support is available through any of them. And nobody else does either. So what we can do is we've centralized the intake to the Seniors Mental Health Integrated Referral Form, which is available via the link in the session description. And people can put in just that one form, and then all referrals are discussed once a week, and people are matched up with the most appropriate support that's needed at that time. So I'm going to switch gears a little bit and talk about a few definitions here. And if there's any questions about our program, please type them in the chat box or to take notes, and we'll be happy to answer these at 12:45. So mental health is the state of our psychological and emotional well-being. It is a necessary resource for living a healthy life and a main factor of overall health. It does not mean the same thing as mental illness. However, poor mental health can lead to mental and physical illness. Good mental health allows us to feel, think, and act in ways that help us to enjoy life and cope with its challenges. For older adults, although mental health is an individual resource, although it is an individual resource, it is influenced by a complex interplay of individual characteristics and cultural, social, economic, and family circumstances at both the larger, like macro level, and at the micro level as well, and all of which make up the social context in which seniors live. And That being said, mental health can be promoted and supported or neglected and undermined at any of these levels as well. So as a support person, we could be trying to intervene at any of these levels, trying to figure out what are the gaps or are there barriers being experienced, and connecting the older adult, their family, friends, and caregivers to the necessary supports. Mental illness is the reduced ability for a person to function effectively over a prolonged period of time. It could be caused because of significant levels of distress, changes in thinking, mood, or behavior, feelings of isolation, which has been a big challenge this last year, loneliness and sadness, the feeling of being disconnected from people and activities. And Canadians that are affected with mental illness may not be able to cope with the simplest aspects of everyday life. They may need help to regain a healthy emotional balance in their lives. And that's where we do encourage people to reach out for the supports and for professional help. It's very important. As we're reaching out for help, what does that help look like? And it's important to talk about something called the recovery model. So previously, going back decades, we had the psychiatry movement, then it was criticized, and there was an anti-psychiatry movement, and then people advocated, usually caregivers, for their loved ones, that their loved one who's been impacted by a mental illness can live a full and productive life. And that's where we're at right now. We use something called the recovery model. It's the personal process. Oh, and by the way, it might feel like I'm reading, but I think I was sensitive. Some people might have some hearing aids and might have trouble hearing me. So I've put up, it's kind of like my speaking notes. So that's why it feels like that. So recovery is the personal process that people with mental health conditions experience in gaining control, meaning, and purpose in their lives. It can mean different things for different people. For some people, recovery might mean they don't want any more symptoms, and that's their goal. And for other people, it could be learning to cope with their symptoms, or maybe having a reduction in their symptoms, and wanting to live a full life with their new normal, and that could be their goal as well. So individuals can learn to believe in themselves as individuals. They can recognize their strengths as well as maybe some of the challenges they experience. They realize that they have the capacity to find purpose and enjoyment in their lives despite the mental illness. And the potential for growth within the individual can be developed by integrating so medical, psychological, and social interventions. And this is a graph that I found that illustrates like what are the components of recovery. Some words that jump out at me is it's non-linear. So sometimes it's not like a straight track. We can have like ups and downs, stops and halts, back and forths. And the goal is to empower the person and to have it be person-centered. There's usually 4 stages of recovery. First is hope, as somebody kind of feels like that, that there could be a different outcome for them. It doesn't have to be so hopeless. And as they kind of move down that trajectory, there's empowerment, then self-responsibility. They might be able to take over their own care in their own life, and they have a meaningful role in the life that they want to live. And the barriers that people experience in recovery is that there could be impairment depending on what the mental illness could be. There could be dysfunction. There could be some disability from the mental illness, and of course, disadvantages. So these are some things that might get in the way. And if we're a support person, we can target any of these areas to support the person that we're providing care for. So next, I'm going to talk about aging and ageism. So this quote is very beautiful. It says that aging is a lifelong process involving the interaction of biological, psychological, and social processes. Biological changes set the broad parameters for aging, so people's reactions slow, they may lose some strength and flexibility, and their sensory functioning may diminish, but they can draw on psychological and social resources to compensate for these changes. Ageism views older people as decrepit and depressed. There's this idea that memory and intelligence, they progressively decline with age. And this definition from the World Health Organization says that ageism refers to the stereotypes of how we think, prejudices of how we feel, and discriminations of how we act towards others or oneself based on age. Some kind of startling and surprising information that half the world is ageist against older populations. Ageism is associated with earlier death by 7.5 years, with poor physical and mental health, a slower recovery from disabilities, so illnesses and conditions in older age, and increased in risky health behaviors. So maybe having an unhealthy diet, drinking excessively, smoking. It reduces the quality of life, and it's actually very expensive as well. So in the USA, it costs $63 billion in healthcare spending. So 1 in every $7 spent on healthcare. Let's challenge ageism. Given the negative stereotypes and expectations of older people, the tendency exists to mislabel potentially treatable problems as irreversible aspects of age or disease. So sometimes I've been in situations where somebody might be referring to an older adult as cute or sweet. And when we do that, when we have these labels, we miss the signs of what could be going on for them. And if we're missing those signs, we're not assessing properly, and we're not targeting what the issues can be. So we need to be mindful of this. There is a growing body of knowledge about the aging process, and it challenges a lot of these negative stereotypes. So the truth of the matter is older people are often competent and enjoy their lives. The aging process is characterized by both the possibility of growth as well as decline. Memory and intelligence remain actually pretty steady on average and can sometimes improve for people in their 60s and 70s. Dementia, depression, and other serious disorders identified with later life impact only a minority of older adults and are not like an intrinsic, so normal part or a universal aspect of the aging process. So timely and well-conceived clinical interventions can make a big difference. Many older people retain their resiliency and can respond very, very positively to mental health interventions, which we see day in and day out in the work that we do on this end. We are also finding out that psychotherapy is effective for older adults and their family and caregivers. Older adults themselves are turning more and more to mental health professionals for help. And before, we had an attitude that older adults might not be interested in receiving psychotherapy. The other thing that we're finding out is that older adults view psychotherapy positively. They might have had therapy in the past and might not stigmatize it. And also adult children, caregivers, and family members are increasingly consulting with mental health professionals. They might have less inhibitions to seek for that mental health treatment. So if we view the attitudes and beliefs of an older person as old-fashioned or out of step with the times, we miss the opportunity to engage him or her or them in a meaningful therapeutic process. So I'm going to talk about some selected problems and disorders. This is a very complex area of mental health. And so it's not possible to cover everything in the short time we have together, but I tried to pick some that are more common or of concern. So first we'll talk about problems and disorders that impair cognition. So First, I'll talk about delirium. It does require urgent and immediate medical attention. This could be a life-limiting condition. It has a rapid onset. So how do we recognize it? It's quick. It's happens within hours and days, and there's usually a dramatic change that we can see in an older adult. The older adult functioning adequately suddenly develops some kind of impairment. So there's kind of 3 ways to organize this. So they might have delusions. So delusions are beliefs and thoughts that kind of seem a little bit out of scope of reality. Hallucinations have to do with sensations. So like what we're seeing, what we're hearing, tasting, feeling, or they could be having illusions. Number 2, they could be either restless, agitated, vigilant, or quiet, subdued, drowsy, difficult to arouse as well, or any combination of 1 and 2. They could show altered mood, which could range from like a high kind of a euphoria to fear. And they might, as we're kind of interacting with them, they might have poor contact with reality. And sometimes it seems like they're living in a bit of a dream. And what I'd like to say is it's often treatable with very good outcomes. Next, I'll talk about dementia. It's a syndrome, not a disease, which means it's progressive impairment and deterioration at the levels of memory, intellectual abilities, habits, and personalities, and the rate varies. So there's different subtypes, and each of them has a different kind of progression. Dementia is acquired, so it doesn't exist at a certain point and then it becomes acquired. It's persistent, and then it involves impairment in multiple domains of intellectual functioning. So to just kind of keep it neat and tidy, language, memory, visuospatial skills, general intellectual abilities. And then on this slide, it kind of highlights what some of this might look like. So if we're worried about somebody with dementia, maybe even if we ourselves are worried about this. So really it depends on what area of the brains are impacted, and the impairment shows up in different ways. And like I said, there's different types of dementia. So we could be impacted at the level of language, memory, visual processing. We might not be able to carry out complex tasks. So if people are having difficulty with dressing or not being able to do certain things, there might be movement disorders. So like trembling, either when we're at rest or for moving, we might slow in our mental functioning. So like our processing. We might experience a lack of motivation, difficulty with learning and retrieval. And sometimes if there's cueing, the performance improves. Even though it is what it is, but the performance does improve and we can improve somebody's quality of life with this. So I have a client, for example, whose family members have put Post-its like absolutely everywhere, and it cues their loved one for different things that the loved one has to do throughout the day. And it improves their quality of life significantly. And sometimes it's practical things on these Post-its, and sometimes it's attending to the emotional aspects of things as well. With dementia, sometimes there's personality changes, like anger, for example. There can be disinhibition of behavior. So like maybe that could show up as like inappropriate dress, impaired social behavior and judgment, maybe not a great insight. And we could have profanity, so impulsive behaviors, profanity, or poor judgment in managing finances. So if people are suddenly kind of like, not suddenly, it happens slowly over time. And so sometimes it's hard to notice it because it's a slow onset. But we might notice that an older adult might be struggling with their finances or might be making some poor decisions. And can be particularly vulnerable to scams, actually. Dementia might show up as a lack of initiative, poor hygiene, and neglecting their responsibilities, maybe like feeding their pets, emptying out litter boxes. The mood can be blunted. So blunted means like a little bit of the emotion, but not the full emotion, or it could be like all out euphoria. They might have trouble with word finding, might have difficulty naming things, and might have issues with things that used to be familiar to them. And as they're kind of thinking it out, they might repeat certain syllables or words, or might talk around the word that they're having difficulty finding with descriptions. And these last three things on here, I kind of mentioned them, describe them. Before we get to a place of dementia, which is a diagnosis and a place of no disorder, there's like this space. And in this space is something called mild cognitive impairment. So people, so this specifically applies to people who might have some impairment, but do not meet the diagnostic criteria for dementia. So things are starting to like show up. And it often looks like depression or anxiety. And what's really, really important is that neurocognitive testing is needed to be able to distinguish. And it is important to get that timely help too, even for depression and anxiety, which I'll talk about in a moment. Sometimes, depending on the cause, impaired cognition can be reversible. So recently, this heat wave is asking a lot of my clients, are you drinking enough water? Because dehydration can lead to that impaired cognition. I won't read through all of these. I'll just kind of point out some of these. So if somebody has a fall, we might want to make sure that they get checked out, because if somebody has a fall and they bump their head, there could be like a bleed in the head, and that could be causing impaired cognition, which won't show up right away. It might take some time, and it could also, depending on the kind of hematoma, show up in different ways. So it's really important to get checked out. If people have low oxygen, especially if they have certain types of like physical health concerns, that might impair their cognition as well. Nutritional deficiencies like problems absorbing vitamin B12, low levels of vitamin B1 and B6, which we actually see when people have alcoholism, troubles with alcohol misuse. This could be a potentially reversible cause of cognitive impairment, and poisoning, brain tumors, infections. So there's some protective factors for dementias, which is depending on the person's level of education, if they speak more than one language, if they're engaging in cognitive leisure activities. So getting involved in those day programs, maybe doing some of these cognitive games at home. Increased social interactions is really important and protective. Physical activity is important, and maintaining proper nutrition as per Canada's food guide. And predictive factors of dementia, like again, education, social isolation, which has been a huge concern this last year and a half. Health and medical factors, and then bioage and biomarkers. So this is more at like a medical place where maybe a healthcare professional is calling for certain tests, which would kind of indicate and point towards dementia. So next, I'll talk about problems and disorders that impair affect. So affect meaning like our mood and how that presents. So first I'll talk about depression, and actually it's the most likely reason for an older adult to reach out for mental health help. In age-ism, older adults are often portrayed as sad, lonely, isolated, and this kind of presentation that's depressed and hopeless and very dreary. The reality is older adults are actually generally satisfied with their lives, and less likely than younger people to suffer from depression. It's twice as common in women, and as people age, especially as they get older, over 75, the rates kind of equal out. Depression in older adults, there's often coexisting conditions. So there can be anxiety and depression together. We can have with people that might have dementias, they could have depression. If there's personality disorders, we might see depression. And with schizophrenia, we could see depression. And this depression does improve often with treatment. And even though somebody might not meet the criteria of major depressive disorder, there's usually, there can be depressive symptoms, which could be causing impairment. And so from going from 0 to 100 might not be like a good way to kind of support somebody. We can also look at what are the gradients in between there. As we age, sometimes we can have medical conditions, and sometimes a few medical conditions. And when this happens, we're at a higher risk of having depressive symptoms. And if we are recent immigrants and we have increased social stress, so these are the layers now. So these are layers of complexity, which increase the rates of depression depending on what's going on in somebody's life. An older adult in long-term care is particularly at risk for depression, and it can be very, very tricky to distinguish. Is it depression or is it due to something else? Because a person might complain of like poor sleep, fatigue, and pain, which could be from a different cause. And some common medical conditions associated with depression in older ages is age-related vision loss, dementias, neurological conditions, stroke, and chronic pain is actually a really big one. It can be associated with depression. Interestingly, for depression in older adults, it's not so much that there's increase in depressed feelings. It could be a decrease actually in positive feelings and emotions. And there's two ways to kind of look at it. The person might have been living with depression over the span of their life, and it could be an aggravation of the depression, or if it's a new depression diagnosis, that's a little bit different and it presents a little differently. And I think what I'd like to just point out there is that if there's vascular change, so changes in the blood vessels, it might not respond well to treatment if it's a late diagnosis. And it's really, really important because it's complex presentation that we need to do proper assessment. And we do, it's important to have interventions at multiple levels. So the biological, maybe like some medications, and behavior and cognitive, which could mean different things like therapy.
I don't know if anybody else have. There we go. Go ahead, Garima.
Oh, thank you. So the rates can be very high. Bipolar is characterized by like an up and a down. And so the up is kind of like a manic presentation. And as we age, this can look like delirium actually. And it could look like maybe like dementia. And so it can be really hard to diagnose this. And so the rates can be very high. So I wanted to put this on the radar. Anxiety. So there's this misconception that it could be triggered by fear of dying, which is an ageist view. But the truth is that there's no particularly increased fear of dying in older adults than other ages. And its prevalence, anxiety's prevalence rates are just as high as depression in older adults. And it's underreported. And the reason for this is that older adults might have, they might have some great strategies and routines and rituals that they have like completely refined over their lifetime and that allow them to function in their life. They might think it's normal to feel like this. And what brings them to seek for help could be like that there's something that happened and they'll focus on that thing that happened. And so that's where it becomes important to, again, have that comprehensive assessment, because then we can see what's been the pattern for them. It can coexist with other conditions, especially depression and medical conditions, and it is associated also with vision and hearing loss. So how does it show up? An older adult might complain of headache, chest pain, fatigue, stomach issues or digestive issues. It's believed to implicate or fight or flight response. So there's a trigger and then we have this fight or flight response. And so just because of the nature of that reaction, the person might not directly address the trigger. They might have these strategies to kind of feel safe. And that avoidance comes at a really high cost for people, and it's involuntary. They might not even have the insight into that. I think the only other thing I'll say here is that alcohol and caffeine contribute to anxiety. Oftentimes I'll ask a client if they're anxious, how much coffee are they drinking in a day? Because it can really increase that anxious anxiety for them. And if that anxiety is part of a personality character for them, it can trigger depressive episodes, but not vice versa. If somebody's got that depression as part of their characteristics, it won't trigger anxiety. Next, I'll quickly touch on personality disorders and psychotic disorders. So psychotic disorders, so schizophrenia, the very late onset is very rare actually. More likely it is that the person will have long-standing schizophrenia. And if it's a late onset, it can be very, very, very impairing. So the person could have hallucinations. So the auditory, so hearing voices, maybe sounds, songs. They could be seeing things or maybe feeling things. And all of older adults that have a late onset schizophrenia or very late onset show evidence of delusion. So like it impacts them at the level of what they believe about the world that they live in. Personality disorders. So I'll read the quote. Personality disorders are disturbing, disruptive, and difficult to treat. It's associated. So if somebody, okay, so this is a really hard one to kind of figure out that this is what's going on for a person. It shows up in certain ways. There might be a pattern of fragile, conflicted relationships. There could be ruptures in relationships, estrangements. If they worked, they might have functioned poorly, or there might be inconsistent employment history. There's usually outbursts. There's usually suicidality and other self-harm behaviors that we would see. And these patterns of behaviors, and this is the thing to keep in mind because they can be just so intense, might interfere and intense for the person who's suffering and also intense for other people, but it might interfere with communication with professionals. It might be a barrier to getting help. If it's usually a long history. If it starts, and if we're uncovering it later on, it's maybe after a loss, or there's other things that that are starting up for this person, which kind of brings this personality traits or disorder to the surface. And what we need to be mindful of as maybe support people, family, caregivers, is that it can evoke an angry and punitive response. And so this person's genuinely suffering and the response they're getting is angry and punitive, and it's not very helpful or supportive. The suffering is real. There's usually a history of trauma, and the person can lack skillful behavior to receive help. So one of the best treatments is dialectical behavioral therapy. And just a couple of things I'll pick off of this page. is that there's an interaction for the person who's suffering in between their own biology and how their environment reacts and responds. There's an interplay and interaction there. The person usually has some dialectical dilemmas that go on for them. So it shows up as kind of like an either or type of thinking, or a very extreme kind of extremes in behavior. And in DBT, we go through 4 levels and stages of treatment in which we target different things. So I wanted to put this out there because if somebody does struggle, suffer, live with a personality disorder, there is help out there. And this is what it looks like. So I'm just going to do a time check on myself and just check to see if the other panelists are here. If somebody can maybe help me check that, Candace or Sam, if you're here.
Yeah, they're all here currently.
Yeah, okay. So maybe I'll invite us to, are there any questions at this point?
So, Garima, we do have one question so far, and I assume we will get more when we open up to panelists. Would you like me to ask that question now?
Yeah, I think let's start taking the questions. Our panelists are all here. So we have today Katrina, who's joining us. She's a social worker, and she's also a designated capacity assessor, a commissioner of oaths. She's an ID authorizer. She sits on the ethics committee at Covenant Health as well, and she brings a lot of expertise and knowledge. We have Toyin, who's a registered nurse and a nurse clinician in our program, who has so much experience. He's worked at the Villa Caritas before. He works in our program, and I believe he's practiced nursing in a total of, I think, 4 countries. And we have Devona, who is a registered psychiatric nurse. She's very seasoned. She's had different roles in our program, and brings a lot of expertise to our panel as well. So why don't we go ahead and ask that question?
I can very gladly do that. So our first question that we received a little while ago in your presentation was to please advise what makes a good CGP referral? What geriatric symptoms are considered CGP eligible?
Maybe Devona would be the best person to answer that.
Hi. So what makes a good CGP referral is, well, anybody who needs mental health assistance, of course. The more information, the better. We do recommend that the mental health or seniors mental health integrated referral form is used. So there are spots to put all of the information we would like to know about the person that is being referred. As far as geriatric syndromes, of course, mild cognitive impairment would be one of them. If somebody is having a lot of falls, if continence could be an issue, full dementia, not so much. We don't take just because there are better services, or they could be helped better elsewhere than with us. We do tend to take on the dementia cases that have behavior issues as well. Yeah, does that answer your question, Zizi?
I believe that takes care of that question. I would encourage at this point in time for any other questions in the Q&A to be put up there again. On Q&A, it is anonymous ask. If you feel like you want to use chat as well, go ahead and do that too.
Are there any other questions right now, Candace? Because I can keep going, and then as the questions come up, we'll ask the panelists.
I was just going to say at this point in time, no questions, so please do continue and I will watch out for that.
Okay, thank you. So next, I'm going to talk about elder abuse and then the suicidality of older adults. So in terms of definition, okay, here we go. So there's a couple of definitions of elder abuse. Elder abuse is any action or inaction by self or others that jeopardizes the health or well-being of an older adult. And it happens within any relationship where there is an expectation of trust. And that's the definition used by our team, the Seniors Protection Partnership team. And the World Health Organization defines it as a single or repeated act or a lack of appropriate action occurring within any relationship where there is an expectation of trust, which causes harm or distress to an older person. So elder abuse is quite complex, and so there's a lot of definitions out there, but the one that we use is the one by the Seniors Protection Partnership. There's different types of abuse. So as I get into this, if it's feeling triggering, please take care of yourself. So there's physical abuse, there is psychological or emotional abuse. There can be sexual abuse and elder abuse as well. Financial exploitation, which tends to be the one that seems to be, in terms of what we see, like the one we encounter the most. So it could be a misuse or stealing of an older person's money or assets, neglect or abandonment, and medication abuse. There's a couple more I added here. I think the top of it might be cut off. So there's cultural abuse. So it's using a person's culture or beliefs and their values to disempower. It can be criticism, preventing somebody from participating, or forcing a senior to behave in a way that is against their values, their norms. It could be threatening deportation, destroying immigration papers, treaty documents, using a person's immigration status against them. It could be threatening to harm person in another country, and threatening to take away permanent residency documents or passports. And spiritual abuse is a criticism of or preventing somebody to participate in their spiritual practice. So forcing somebody to behave in a way that goes against their beliefs. It could be also a misuse of scripture to support abusive behaviors. Forcing somebody to engage in spiritual religious practices against their will, or even a faith leader dismissing or denying that there is abuse going on. Are there any questions about elder abuse? There's certain risk factors. So in this last year and a half, there's been an increase in isolation. So even beforehand, anecdotally, we believe that elder abuse is it's underreported. And so in the last year and a half, where services might not be available, like home care or other supports, this has increased the isolation of older adults and putting them at a greater risk for elder abuse. So this can sometimes be caregiver burnout can be a huge cause towards elder abuse. And so it doesn't always come from a malicious place. It could be from a place of burnout as well. And it's important to reach out for this support when we're feeling this way. So there's some resources that I put up on this slide here if people would like to get more information. People are also welcome to ask our panelists and any questions as well. Something that can be very protective against elder abuse is to have some advanced directives made and put into place. So the older adult, anybody actually over the age of 18 can make a personal directive. And I think I'm going to ask Katrina in just a second to explain these a little bit more. So there's something called the power of attorney, which has to do with finances. And an older adult can make this. Usually we're looking to make an enduring power of attorney. There's a document called the Goals of Care, which can be made with the assistance of a doctor. And a will is how our assets taken care of after we're gone. If we don't make the personal directive and power of attorney before we reach a certain point, then it's a different type of application. And this is usually like, it takes time and it's expensive, and it can be kind of cumbersome. And then that's the guardianship and the trusteeship. So maybe Katrina, can I ask you to talk about these a little bit?
Sure. So the personal directive is about all non-financial matters. So that could include healthcare, where you live, legal matters. It includes a few different other domains, but usually for older adults, such as employment or education, they don't necessarily apply anymore, but they could. So usually we recommend for everybody to have one, and social workers or anyone can witness them. But it's important to look through them and try to put those together when you're able to name who you trust to make those decisions, if it ever came a point that you couldn't make those decisions for yourself any longer. And then the power of attorney, there's a few different kinds of powers of attorney. Generally, we are recommending an enduring power of attorney, because those are a document that can start, you can either name it to start as soon as it's signed or not to start until you require it. And that's when medical practitioners, usually two medical doctors, determine that's needed. And it endures past the point of capacity. So if you start it now, it endures past. So that's usually the kind of power of attorney we recommend, and it's only for financial matters. Generally, we recommend getting a lawyer to assist with that, especially if you have any assets, especially if you have any land or property, because land titles requires a lawyer to be a part of that process. But if there's no assets, no property, then sometimes a social worker will assist with that if it's very minimal assets. So those are two important documents to put together. If you don't have those and the time comes that you unfortunately lose capacity, then it can be an expense and some work for your family to try and support you through guardianship and trusteeship. And you don't necessarily get a say in who is the one supporting you. So you want to be able to name who you trust when you have that ability.
Thanks, Katrina. Are there any questions?
There are no further questions at this time, so you can continue, Garima.
Okay, this is one of the most asked questions actually that I get. I'm sure Katrina gets this a lot too. So we welcome them for this topic for sure. Next, I'm going to talk about, so again, this could be triggering for some people as well. So if you're finding this topic of suicidality to trigger you, so you might be having some body reactions or maybe your thoughts start racing, please take a pause. You can mute me if you need to, walk out of the room, or reach out for support. So suicidality of older adults. The definition here, so suicide means that somebody ends their life on purpose. However, people who die by suicide or attempt suicide might not really want to end their life. It might seem like the only way to deal with difficult feelings or situations. So maybe they're experiencing a lot of pain, emotional pain, and they've tried other ways to resolve that, and kind of not being able to do that. And so now ending life to end that pain might become something that comes to them. Older adults die by suicide at a much higher rate than any other age group, believe it or not. And older males die by suicide more often than any other group. And it's because they tend to use more lethal means when attempting suicide. So older men will use greater intent and greater force. And also older adults, they have less attempts. They'll have 3 attempts per 1 completed suicide. Whereas youth, for example, just the statistics, everyone's situation is different. Youth might have 200 attempts for 1 completed suicide. I think I'll leave it at that. So risk factors. There's a previous suicide attempt. There might be a loss to suicide within a family or friends, which kind of removes the barrier of taking this step for people, and that's why it puts them at a greater risk for it. There might be serious physical or mental illness. That people might be struggling with drugs or alcohol. So this again reduces barriers for them to take to act on their plan. Sometimes another risk factor can be a major loss or changes in their relationship. It could be major transitions, so like phase of life issues. So for seniors, maybe retirement or other things like moving out of a house or moving into care, or kind of having these transition periods in their life. These could put them at greater risk. Isolation and lack of support network, elder abuse, and of course the access to the means put them at greater risk as well. So these warning signs, so the American Association of Suicidology uses this acronym, and the Canadian Mental Health Association Edmonton Region also uses this acronym called IS-PATH-WARM. So it stands, like all of those letters stand for different things. And these are the warning signs to look out for. So if somebody's thinking about suicide, so sometimes it could be like thoughts and we're not wanting to act on those thoughts. And sometimes we're thinking about it and we might have a plan and we might even know when we want to act on these thoughts. So if we're a concerned person, we can check in to ask like, hey, I noticed you said these things. And so I'm just checking in. Are you thinking about ending your life? And do you have a plan? And do you know when you might act on it? And then we can connect them to support, because we do need support in these situations. It could be any changes in substance use. So if somebody has issues with drugs or alcohol, and maybe there's an increase in their alcohol or drug use. Somebody might be feeling purposelessness. So they're kind of feeling like there's no purpose for them to be around. They might not be feeling productive. They might not have a reason to keep living. And this can show up in different ways for different people. There might be intense anxiety, feeling very overwhelmed and unable to cope. So and this can be a perception thing. So as people around an older adult who kind of have a different view on their situation, we might see that they have what it takes to cope with their situation, but the person, the older adult themselves might not feel that way. They might feel trapped, like there's no other way out of their solution, and feeling hopeless and helpless, and like things cannot possibly get better. They might withdraw, and with the withdrawing, like there might be people around them, but it's like a perception again, like they perceive that they can't talk to their family members, friends, and they can't have that connection and be able to share their inner turmoil. There might be anger, which might be showing up, recklessness, so taking risky or dangerous behaviors. So like maybe driving recklessly could be one of those things, or it shows up in different ways, and changes in mood. So sometimes we kind of have this perception, if we're not seeing a person's turmoil, that they're okay, they've decided to keep living. But the reality is they could have just made a decision of what they're going to choose. So if we notice somebody struggling and suddenly there's been a change and they look happy, upbeat, kind of peaceful, we can ask them, hey, just want to check in, because that decision might have been made to act at a certain time, and that could be what's bringing that about. So if we're worried about somebody who's an older adult having thoughts of suicide, or even an older adult or any age person dealing with suicidal thoughts or wanting to act on those thoughts, there is help. Please reach out. And these are just some resources that I put on here. Are there any questions at this point?
Yes, we do have one question, Garima. This question is for Katrina. And the question is, Katrina, have you come across the situation when cultural and or personal values can create complexity to make decisions about goals of care, power of attorney, or end of life? So the complexities if we are having a bit of a cultural or personal value difference.
Yeah, I think that can play a role for sure. And that's why it's important to talk about it when the adult is able, because it's important to get their viewpoint, if possible, directly from them. But that it can create some challenges, especially if it's after the point that they've lost capacity. And then we're hearing from multiple family members with different viewpoints, all trying to speak, what they think is the best for their parent or spouse or whoever. And then they have maybe different cultural opinions, maybe from the medical team as well. So it can get very complicated. One of my roles is actually on the ethics team for Covenant Health, and that's where that sometimes comes into play, is an ethical consultation, because sometimes we just need that other perspective to see where are we following the patient's best interests, and get another perspective on things, because we want to make sure that we're doing right by the patient in those situations.
Thank you, Katrina.
Mm-hmm.
Are there any other questions?
Not at this time, Garina, so you please carry on.
Okay.
Okay.
I'm just changing the slide. Just give me a second here. So I want to talk about caregivers for just a moment. So 1 out of 4 people in Alberta who are 15 years old and older, they're a caregiver. And they provide care for somebody in their life. Caregivers are the backbone of the healthcare system. That's what they're called. And they save our healthcare system $5.8 billion every single year. And they contribute about 400 million hours of unpaid care in a year. And so what happens is, like, caregivers, and often we do also ask them to take up care of older adults if there's something going on and we need help with something. But there's not a lot of supports out there, or we forget to check in with caregivers. And so caregiver burnout is real. So there's this organization called Caregivers Alberta. And this is a number, it's toll free that people can call. The Caregivers Alberta website's actually really great. There's a really good resource page on there. I didn't link it in the presentation slides, but when I think these slides are going to be posted somewhere, I believe, I'll put in the link. And so caregivers, I just want them to know that there is support out there, and we're starting to, as a healthcare system, know that we need to also have not just client-centered care, family-centered care, but also caregiver-centered care. And when we're putting requests on the shoulders of caregivers, and maybe, like, I think caregivers are happy to participate in care, and they feel like they want to, but we also need to check in that do they have the support that they need to provide that care. So I wanted to talk about this for just a moment. We've covered a lot of information in a very short amount of time. So just like some key tips, I guess. of what to look for if we're an older adult or looking after an older adult. If we notice changes, so are we noticing like confusion? Is this person able to tell us the time, day, place? If this is a no for this, we need to reach out for ambulance or maybe connect to a family doctor right away. And then is there changes in appearance, mood, behavior, appetite, weight, energy, or sleep? And this could give us clues if there's things going on with the mental health. So are we moving from a place of wellness to having some I'm starting to lose words. Are we having from wellness to some impacts, impairments, dysfunction, and have we reached the place of having disorder? So we want to notice those changes. And it didn't talk about substance use or addictions in this presentation, but older adults do sometimes live with substance use and addictions. And has there been a change in those patterns as well? Those are things that we can keep an eye out for. So this is the name of our panelists. Are there any questions at this point?
So at this point, we do not have any further questions in either the Q&A or the chat. I suppose we would give just a few more seconds here if anybody does have interest. Oh, let's see, I got something here. All right, here we go. This question says, what are the options for accessing CGP with language and cultural barriers when mental health issues have taboos to talk about? In other words, mental health is not a presented or identified issue.
Can you repeat that?
Sure, I can. Question is, what are the options for accessing CGP with language and cultural barriers when mental health issues have taboos to talk about? Mental health is not a presented or identified issue. So what other options could you provide? I believe this is reading if as a caregiver, you are seeing mental health issues, but it's not culturally acceptable or there's a barrier there to talk about. And again, the person asking this question has identified there are two separate questions here. So the first one, accessing CGP when language and cultural barriers are there regarding mental health issues. What options can you give?
We would still accept the referral. If the patient is willing to see us, we would do, of course, our best to have interpreter services if needed. We do have a few staff who speak different languages, so we try and accommodate as much as possible. For cultural beliefs, we always recognize those as well and trying to accommodate the patient as much as we can there. The second part where you say mental illness is taboo in some cultures, if I understood that right, is that what you're asking? Yeah.
Yeah, it was kind of the second part of that first question. What other options if there is a taboo nature around that? Yeah.
Yeah. So I mean, we would try, but highly likely the referred patient would refuse our services. We do try and talk our way into every case that is accepted into our service or meets the criteria, I guess. But for cultural taboos, again, we would try and incorporate, our staff who are aware of such culture, use the interpreters. Again, the physicians are very well versed in a lot of cultures as well. So as far as other options to recommend, I guess the cultural communities themselves could help out that patient as well, or, if give us a hand in educating us on things as well would be really good, actually. Do you have anything to add, Garima?
Yeah, I'll add, and I'll ask Toyin too if he's here to add as well. So I think just adding to what Devona is saying, I think for ethnocultural communities, something that gets in the way to accessing supports is knowing if what they talk about is going to be confidential, because one of the barriers is that you want to keep private issues as private, and the things that are from the home in the home. So I think one of the things that service providers can do, and especially from our program, is to explain that it's confidential, and we cannot share your information without your consent. All of us have access to interpreter services within our appointments. Like Devona said, some of us speak multiple languages, some of us walk two cultures or multiple cultures, and so we have awareness and insight of within our team of what could be like cultural norms for different communities. I think something that's very important is partnership and collaboration. So who else is part of the care team? So if a referral is coming towards us, is the family physician, can they be a partner and collaborator in the care? Is the client comfortable with us involving their family in their care? So like the partnership and collaboration becomes like important. I think when people from ethnocultural communities talk about mental illness or mental health issues, they tend to talk about it in a somatic way. So instead of talking about, and this could be like from a place of language where there are no words to describe what mental illness could be in another language, in another culture. So the way they're describing it is physical. So it's us having awareness and being able to meet the client where they're at, to kind of understand that what they're talking about could be related to mental illness, and then kind of educating and engaging with the client as well. I think those are some things that just come to my mind off the top of my head. I think I'll also invite Toyin if he's here to speak to this one as well.
Yes, thank you very much. Please, can you hear me?
We can hear you.
Okay, yeah. The best admission starts at the point of referral. So we do have very solid processes in place to screen patients and at the onset, such that we're able to pick up any culturally significant factors during the referral. The intake coordinator does that, does the initial contact, and while trying to ascertain the appropriateness of the referral, she's able to pick that out, and in assigning, although we cover various, we have circumscribed zones which we cover. If there is anything of cultural significance, and the intake coordinator usually taps into the multicultural nature of our team. We've had situations where someone that is familiar with a particular culture have worked with other clinicians out of their zones. And we've also had situations where the patient is totally transferred, is completely transferred to a clinician who is familiar with the culture, because that also brings familiarity into the care, into our patient-centered care model. Another thing that is very important is family involvement. typically it's a generational thing where, I mean, this country is a country filled with immigrants. So typically there's always someone in the family, either the adult child of the client, or a grandchild, or a cousin, or just some family members who understand who understand both culture. So oftentimes family members are our bridge. I mean, they are important partners in ensuring that we're able to reach our clients and for us to be able to overcome the issues of taboos and other things that are related to mental health. Devon also mentioned earlier, and Garima, about the use of independent interpreters, because we do factor in the fact that, you know, if abuse is involved, we make sure, I mean, abuse is usually perpetrated by caregivers, either family or non-family members, and others who may have contact with the patient. So we also tread cautiously in that regard, just to make sure we get the appropriate information by using professional interpreters. So I really do hope that helps. So succinctly, family involvement, initial screening at triage, and involvement of and utilization of the multicultural team that we have. So those are the ways we've coped with. We have successfully handled our culturally diverse clients. Thank you.
Thank you very much.
Yeah.
So we have another question here. It is a two-parter. The first part of it is CGP available to provide services to a client who is connected with a non-AHS community psychiatrist? And the second part, how about if the client is connected with an AHS psychiatrist already, but would benefit from additional community services? Would CGP be able to provide those services?
Hi, typically we wouldn't accept somebody who already has a psychiatrist, because that's double dipping into resources, and it's discourteous to their current provider. So what we do ask when we get those referrals is if their current treating psychiatrist would like to transfer care to one of ours, we just like to have the conversation to be had between the two doctors to transfer care. So that would apply also to AHS and non-AHS psychiatrists.
Thank you very much. And we have a final question today in consideration of our time. It's just going back to the mention of accessing interpretation or helping with those cultural barriers sometimes in support. So the question is there funding support to access interpretation services, or does that fall onto family and friends to provide?
If I may take that, yes, the need for funding does not come into place because we do have, we actually have direct online access to professional interpreters whom we will have booked before the appointment, and they will interact directly with the patient while our assessment is going on.
Thank you very much. It's at this point.
So it does not cost the family anything to access interpretation services.
Thank you for that clarity. Yeah. Garima and company, there are no more questions at this time, so we will finish up our PowerPoint. All right.
So before I pass it on, I just want to thank everybody for joining us today. I want to thank all the panelists. I want to thank Candace and Sam and everybody behind the scenes. So I'm going to pass it back to Candace and to wrap it up.
Thank you so much, Garima. Well, here we are Friday at the end of our week, and we are very happy to have offered these sessions for free to our communities. As the more accessible resources we have, the better equipped we can all be together. That being said, if you have the capacity to donate, now is the best time to do so. With the support of EPCOR and their Heart and Soul grant, we've been given the opportunity to have all donations matched dollar for dollar during the Breaking the Silence week. And more donations means more mental health resources and support for everyone who needs it. And then our final slide. Breaking the Silence was started, as you most are aware, by a group of friends to raise awareness about mental health, to create safe spaces, to have conversations and share resources within our communities. We are proud of how the event has grown and the continued support we receive from all of you. We couldn't offer this event without the support of our amazing partners. So thank you. And thank you to everyone for your participation in today's webinar. We hope you are taking away new information that you can integrate into action. And again, this webinar is recorded and will be made available tomorrow for you to share with your friends and family. Have a wonderful day, and thank you again for joining us.